welcome to all of a warm welcome to all of you on behalf of IC Kalyan. Today is our fourth journal club reading and presentation. We are trying to cover different topics which are applicable in our day-to-day practice through CMEs and JC reading. After a long time, IC Kalyan is arranging an offline CME on regional anesthesia. Speaker is one of our favorite, Dr. Bala Venkat. So please book your date for 23rd January 2022. As we all know that we have got a sigh of relief due to availability of SGDs during difficult intubations and maintaining airways during spontaneous respiration in short duration cases. So today we will have our journal club reading on comparative study of IGEL and AirQ, followed by videos on SGDs by Master in SGDs, Dr. Yugin Bhatt. I welcome Dr. Yugin Bhatt and I welcome all our mentors and request Dr. Sanjot Abade to start the session. Who is going to moderate this session? She's our General Club representative.
Okay. Good evening, friends. Our monthly JCP is back again after a brief Diwali break. I'm sure our energy levels are up with all the sweets consumed. No guilt, please, because we are going to spend it all in this very active session. It's an absolute pleasure to have with us Dr. Yogen Bhatt and Dr. Namazi, our esteemed guest for today. After the JCP meet in How I Do in video session, we have a surprise session by these two expertise. They have very interesting videos lined up for us. They are going to give us a visual treat by showing different types of supraglottic airway insertions and also the vision guided insertion of supraglottic airway, and a surprise video by Dr. Namazi, which I'll keep it unsaid. In our journal club presentation today, we have the article on supraglottic airway device for pediatric anesthesia. Airway management is an essential skill in pediatric anesthesia. A challenging airway inadequately prepared for or suboptimally managed can be a determinate factor in morbidity and mortality in pediatric anesthesia. Introduction of LMAs in 1980s and several development in the supraglottic airways has drastically changed the pediatric airway management. They have been used successfully and showed to decrease the post-operative complications like laryngospasm, breath holding, desaturation, nausea, vomiting, etc. So we begin our journal club presentation with Dr. Shweta Jaju, who will be talking on the pediatric airway anatomy and advances in supraglottic airways, followed by Sachin Supe, who will be elaborating the salient features of IGEL and AirQ LMA, and Mayuresh Patel will be presenting the article Supraglottic Airway Devices for Elective Pediatric Anesthesia, IGEL versus AirQ. So friends, sit back for an informative and interesting session. Over to Shweta Jaju. Shweta? Mayuresh, can you help her to begin?
Ma'am, she is there. I don't know. Just one sec. I will.
Yeah, she had joined.
Yeah.
Good evening, one and all. My sincere thanks to ISC Kalyan for providing me this opportunity to be a part of the General Club meeting. With regards to today's topic, let us begin with a brief discussion upon pediatric airway concerns. Neonates and infants have a proportionately larger head as well as a large tongue. Nasal passages are quite narrow.
Shweta, your screen is not seen.
Now it is seen, ma'am?
No.
No.
Okay,
Still it is blank.
It is not shared.
It is not shared.
okay, fine.
Even your video is off, so we can't see you.
Okay, ma'am.
You
Sorry
can
for
again restart, Shweta.
Stop
Okay.
screen share and again
Yes, ma'am. Mayuresh, can you help me?
Share screen karo.
Just share your screen.
Yes. Yes, I can help you.
Yeah, it is just starting.
Yes. This is visible, I guess.
Yes, yes.
Yes, yes.
Make it full screen. Yeah.
In accordance with today's topic, let us begin with a brief discussion upon the pediatric airway concern. Neonates and infants have a proportionately larger head as well as a large tongue. Nasal passages are quite narrow. Larynx is anterior and syphilate at vertebral level P4 as compared to adults where it is at P6. Epiglottis is long, accompanied by a short trachea and a short neck. Neonates and most young infants until about 5 months of age are obligate nasal breathers. Cricoid cartilage is the narrowest point of the airway in children younger than 5 years of age. In adults, the narrowest point is the glottis. So here we can see that even 1 millimeter of edema will have a proportionately greater effect in children as compared to that of adults because of the smaller tracheal diameter. Thus, we understand that pediatric patients are not just small adults. Safe anesthetic management depends upon the full appreciation of the physiological, anatomic, and pharmacological characteristics. Certainly, a few modifications are required in anesthesia technique as that of anesthesia equipment. So with keeping these few concerns in mind, there is a rising interest among anesthetists towards the use of supraglottic airway devices. With these in mind, let us also brief some points about the supraglottic airway devices. Devices that rest above the glottis are called supraglottic airway devices. They isolate the airways above the vocal cord. They practically fill in the niche between the face mask and the tracheal tube. First LMA was developed by Dr. R.K. Bain in 1982 as a modification of Goldman dental mask with endotracheal tube. However, LMAs became commercially available in 1988. LMA Classic was the first one. So now here is the sequence of development of the airway management. In 1788, first reference to tracheal intubation on human beings was done. In 1881, birth of extraglottic airway management was done. In 1934, first cuffed oropharyngeal airway was introduced. In 1981, first human use of pharyngeal mask was introduced. It was only in the year 2002 that single-use second-generation supraglottic airway devices came into role. The year 2003 to 2010 marked the introduction of reusable second-generation supraglottic airway devices. Let us see about the classification in brief. Based on the lumen type, there are single lumen, double lumen, and triple lumen. Single lumen are the LMA Classic, Unique, Flexi, ILMA, C-Track, LED, Ambularyngeal Mask, Cobra. Double lumens are Profil, Combitube, iGel, Busca Mask, and triple lumen are the ELISA airway device. Also, based on the generation, according to properties, the first generation are those with only airway tube. Second generation have additional design features to reduce the risk of aspiration. They have a higher seal pressures to enable controlled ventilation at higher airway pressures. Also, they have integral bite blocks to protect the patients against airway occlusion. Third generation SADs also have a capability to intubate through it. Based on the generation, their examples are first generation includes classic LMA, flexi LMA, laryngeal tube, and Cobra. Second generation, we have the LMA Supreme, LTS, Procil LMA, Bascamas, iGel, which is our topic of discussion of today, and Combitube. Third generation, which is the ELISA and AirQ, which is also our topic of discussion today. Based on the sealing mechanism as discussed by Miller in 2004, they are described as cuff perilaryngeal sealers or cuff pharyngeal sealers or cuff or pre-shaped sealers. So our both the devices of discussion of today come under the topic of pre-shaped sealers. With esophageal sealing mechanism, we have the iGel, and without esophageal sealing mechanism, we have the AirQ. I end my discussion by talking about the advantages and disadvantages of SAD. The advantages being increased speed and ease of placement, less requirement of expertise, improved hemodynamic stability at induction and during emergence of anesthesia, lower incidence of sore throat, coughing, and laryngospasm during emergence, minimal IOP and ICP changes during insertion, and increased airway tolerance. Whereas the disadvantages are inadequate positive ventilation, more chances of aspiration of gastric contents. Sometimes there may be chances of sore throat if insertion technique is not proper, and vascular compression and nerve damage. So with this, I end my talk and I hand over to Dr. Sachin Subbe to carry on forward the discussion on iGel and AirQ.
Hello everyone. Hello everyone. As Dr. Shweta Jadu ma'am had described, highlighted the peculiarities of pediatric airway and importance of supraglottic airway in pediatric population, I am going to talk in brief about LMA of our today's journal article, that is iGel and AirQ intubating LMA. iGel. iGel is a single-use cuffless second generation supraglottic airway device made up of an thermoplastic elastomer gel. Its shape resembles inflated Procil LMA. It has a short wide bore airway tube, an integral bite block, and a gastric access channel in all sizes except size 1. These features provide low resistance to gastro, stability, improved pharyngeal seal, and adequate conduit for tracheal intubation. The elastomeric gel warms up to body temperature, improving the seal of the mask around the airway. The iGel was introduced to pediatric anesthesia practice in 2009. The AirQ is a third generation supraglottic airway device, was introduced in the United Kingdom in 2012. This supraglottic airway device has an oval mask and a curved short airway tube. It also has an orifice designed to prevent epiglottic folding. The AirQ has 3 versions produced for either multiple or single use. First is standard cup, second is self-pressurized AirQ with no inflatable cup, and third is AirQ with an esophageal blocker. This device has gastric channel but is not available in pediatric sizes. One of the main features of the AirQ is its wider and shorter airway tube. These characteristics may facilitate the passage of cuffed endotracheal tubes via this device, both in infants as well as children. AirQ can be safely removed after intubation. These are the pictures of iGel and AirQ LMA for our quick visual impact. You can see from front view of cuffs, and in the second picture, we can view the lateral view of the cuff. And now I will hand over to Dr. Sanjot Abade Madam and Dr. Mayuresh Patil for further proceedings of the meeting. Thank you.
Hello everyone.
Hello.
She- Hello. Is my screen visible?
No, Mayuresh. Mayuresh, go back and double click that. Double click that right lower side.
Is it visible now?
No, no, not yet. Just wait for a second after you press the share screen.
Okay.
वेट करा.
Is it seen?
No, it's written as Mayuresh has started his screen sharing, but we can't see.
Hello.
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 Sir, can you do one thing? Just stop the screen share.
Huh.
Okay. So
Yeah.
now click on share screen.
Yeah.
Okay. So on the left hand side, in the left hand bottom corner of the
Yeah.
screen, there is
Yeah.
optimize sound and video. Can you see it?
Optimize for video clip.
Yes. Click
Yeah.
on both the check boxes and then
Okay.
select the screen first.
Okay.
Okay. Just single click it and then share it. There is a share button on the right hand bottom side.
Yeah. One sec. Is
Yes.
it visible?
Yeah.
Yes.
Now again go to the slideshow for a complete screen.
Yeah. Hello. Welcome everyone. Myself.
Mayuresh, your screen should be maximized.
Yeah, it is maximized.
We are seeing the part of your slides also.
Already. Is it seen?
No.
Mayuresh, you stop screen share. Go back. At the slideshow dabata. Please press on the slideshow option.
Yeah, I have pressed.
No, it is not happening. You go back totally. Stop screen share first. Stop.
Yeah.
Now press the green share screen wala thing.
Yeah.
And then right side, most bottom side line, you will see one share na. Double click on that.
Yeah, but I have to select the article. Na?
No, it will come. You double click on that, you will get your option.
Is it seen?
We can see now.
Yeah. Hello everyone. Welcome to ISA Kalyan, our journal club presentation for today. Today's article title being the Supraglottic Airway Devices for Elective Pediatric Anesthesia, iGel versus AirQ, which is the best. Author being Rami Monir Wahaba, Milad Zarki Ragai, Ayan Anis Mestri, and George Michael Nakla. It is from the Anesthesia Essays and Researches, Volume 14, Issue 3, July to September 2020. My study article is been shown in the following points: study type, aims and objective, inclusion and exclusion criteria, randomization, grouping of the patients, methodology, standard plan of anesthesia, outcome variables, statistical analysis, result, discussion, conclusion, and references. The study design is a prospective comparative clinical trial started in October 2018 after approval by the local ethical committee. It was conducted at the Department of Anesthesia and ICU, Faculty of Medicine, Ain Shams University, Cairo, Egypt. The aims and objective of the study being to compare the insertion facility, effect on hemodynamic parameters, and effective ventilation using iGel versus AirQ Lma for pediatric patients undergoing short duration surgical procedures. Inclusion criteria being the child between age of 3 to 10 years, ASA grade 1 to 2, surgical procedure requiring supine positioning and with the expected operative time of less than 60 minutes. Exclusion criteria are age more than 10 years, ASA grade more than 2, with comorbidities like current or recently resolved upper respiratory tract infection, presence of oropharyngeal, laryngeal pathologies or congenital anomalies, pathologies inducing the reflux or increasing the possibility of aspiration, allergy to anesthetic drug to be used, renal, cardiac, hepatic diseases, bronchial asthma. In addition, the patients who underwent surgical procedure that accidentally required prolonged operative time more than 60 minutes for any cause were excluded from the study. The randomization sample size and grouping is as follows. The parents of the children who were fulfilling the inclusion criteria were asked to choose a sealed dark envelope containing a card label which have a group label. These envelopes were previously prepared by the assistant who was blinded for the significance of the labels. By this method, 174 child were eligible for evaluation, of which 24 got excluded because they did not follow the inclusion criteria. That 12 had upper respiratory tract infection, 4 had acute gastroenteritis, 3 had type 1 diabetes mellitus which was uncontrolled, 3 had history of hepatitis, and 2 had congenital heart condition. So total 150 patients were included, which were divided into 2 equal groups. Group I, who will receive iGel as a supraglottic airway device, and group Q, who will receive AirQ as a supraglottic airway device. You can see by the chart that the patient enrollment data show non-significant difference between the two groups, so both were comparable. Standard plan of anesthesia was like this. The pre-medication was given with 0.15 milligram per kg of midazolam at 10 minutes before induction in preoperative holding area with monitoring of the heart rate, mean arterial pressure, and SpO2 monitoring. Pre-oxygenation was done with 100% oxygen for 3 minutes. Induction using propofol 2 milligram per kg. Then they were ventilated with 8% volume of sevoflurane in 100% oxygen for 3 minutes using a face mask. And no neuromuscular blocking agent was given in our study. On arrival to adequate depth of anesthesia, which was judged by the absence of motor or cardiovascular response to stimulation, supraglottic airway device was inserted by a senior anesthetist with a pediatric anesthesia experience. Maintenance was with 2 to 3% sevoflurane in 50% oxygen through supraglottic airway device with mechanical ventilation to provide a tidal volume of 8 ml per kg and phase gas flow of 3 liter per minute, respiratory rate of 14 to 20 breaths per minute, and end tidal CO2 being maintained 30 to 40 millimeter of mercury. At the end of the surgery, sevoflurane was stopped and lungs were ventilated with 100% oxygen. After the recovery of self-respiration, device was removed. Both the supraglottic airway device were lubricated with the lignocaine gel before insertion. Size was chosen as per the guidelines by the standard equipment. So iGel, for iGel we know there is a color coding as well as size. Size 1 is for weight 2 to 5 kg, size 1.5 for 5 to 12 kg, 2 size for 10 to 25 kg, 2.5 for 25 to 35 kg, 3 size for 30 to 60, size 4 for 50 to 90, like that. AirQ also has color coding and weight criteria. So less than 7 kg child used AirQ size 1, then 1.5 for 7 to 17 kg, size 2 for 17 to 30 kg, 2.5 for 30 to 50 kg, and 3.5 for 50 to 70 kg. After insertion of AirQ, its cuff was inflated with 0.5 ml and 1 ml for size 1.5 and 2 respectively to achieve a cuff pressure of 20 to 30 centimeter of water. Finally, the breathing circuit of anesthesia machine was attached to the airway device and surgical procedure was started. Outcome variables that were studied in our study are primary outcome variables that are studied are success rate of the supraglottic airway device. Supraglottic airway device failure was said when there were 3 failed insertion attempts. What do you mean by failed insertion attempts is either inability to directly insert a device, or device had insufficient ventilation, that is less than 6 ml per kg, or required very high airway pressure, that is more than 30 centimeter of water to maintain the adequate ventilation, despite device manipulation, that is head neck positioning adjustment, changing the insertion depth. In evidence of device failure, endotracheal intubation was performed with relaxant being rocuronium 0.6 milligram per kg. Secondary outcome variable that were studied were insertion time, anatomic alignment of the supraglottic airway device to the larynx, then leak pressure, impact of supraglottic airway device insertion and removal, and incidence of postoperative complication. The insertion time was from removal of the face mask till the stable capnography was seen on the monitor. Sufficient ventilation was said when there is no audible leakage with manual ventilation of 20 centimeter of water and bilateral symmetrical chest movements. Anatomic alignment of the supraglottic device to the larynx was judged by fiber optic bronchoscope inserted through supraglottic device, and best view observed at 1 centimeter above the tip of the ventilating orifice was graded according to Jagannathan et al. Scoring system for fiber optic grading of laryngeal view through device. Grade 1 if only vocal cords are seen. Grade 2 if vocal cords and posterior surface of epiglottis were seen. Grade 3 if vocal cords tip of the anterior surface of epiglottis are seen, which indicates less than 50% of the obstruction to the vocal cord by epiglottis. Grade 4 if the epiglottis was downfolded with anterior surface was seen, it indicates more than 50% obstruction to the vocal cord by the epiglottis. And grade 5 if the epiglottis was downfolded and vocal cord cannot be directly seen. Fiber optic grade 1 and 2 indicate that device position is optimal, while grade 3 to 5 indicate it is a suboptimal position of the supraglottic airway device. Leak pressure was determined by the application of slow increment of the airway pressure with a constant fresh gas flow into the circuit in a closed manual mode until an audible leak sound was detected either from a mouth or from auscultation over the larynx. Tidal volume loss was estimated as percentage of difference between the inspiratory and expiratory volume in relation to inspiratory volume. Impact of supraglottic airway device insertion and removal on hemodynamic parameters, that is heart rate, mean arterial pressure, saturation measures were recorded immediately before insertion, at the time of insertion, 1 and 5 minutes after insertion, and before device removal. Incidence of post-operative complication in the form of nausea, vomiting, blood staining of the device, sore throat was also studied in secondary outcomes. The statistical analysis of the study was obtained data was presented as a mean plus minus standard deviation, ratios, numbers, and percentages. The result were analyzed using one-way ANOVA test and chi-square test. Repeated measurements like heart rate, mean arterial pressure, tidal volume losses were analyzed using paired t-test. Statistical analysis was conducted by IBM SPSS software, and p-value less than 0.05 was considered to be statistically significant. The results were current trial were reported as a total success rate irrespective of a device used was 96%, with non-significantly higher success rate with the iGel, that is 97.3%, then AirQ 94.7%. So success rate at first attempt of insertion was 85.3% and 82.57% for iGel and AirQ respectively, with non-significantly higher frequency with iGel compared to AirQ. Similarly, success rate for the second and third attempt were also non-significantly higher with iGel. You can see in the figure, the bar diagram given below, that in the black gray colored shaded is a iGel in success rate, and in AirQ it is a dotted black dots. On contrary to the insertion time was significantly shorter with iGel. So then with AirQ, in iGel it was in mean of 12.3 plus minus 3.6 seconds. For AirQ it was 13.7 plus minus 4.2 seconds. You can see in the figure below. The fiber optic grading of the laryngeal view through supraglottic airway device was better on using iGel without significant difference for the patients who had a view grading 1 and 2 than on AirQ. And frequency of the patients who had a view of grade 1 was non-significantly higher with iGel than AirQ. We can see the grading that grade 1 and grade 2 was better with both the devices, with iGel being better. The percentage of tidal volume loss significantly decreased at 5 minutes after insertion in comparison to the immediately after insertion in both the devices, but non-significantly lower levels were seen with the iGel than with AirQ at both the times. So in checks format, it is a for AirQ, and gray shaded is a iGel. In both the time, tidal volume loss was lower for iGel at the time of insertion, also after 5 minutes of insertion. Operative time and intraoperative hemodynamic changes showed non-significant difference between both the groups throughout the operative time till the removal of the device. 30 patients developed post-operative complication, of which 9 had a cough, 11 had sore throat, 3 had nausea, vomiting, and supraglottic airway device was blood stained in 7 patients. There is non-significant difference with p-value of more than 0.05 in both the groups. You can see the operative time, heart rate, all the hemodynamic monitors and complications. Both the devices were comparable. With in case of complication, AirQ was non-significantly better, while in case of hemodynamic parameters, IGL was non-significantly better. Discussion: the divergence result were seen in the study. No supraglottic airway device is absolutely superior to the others. The feasibility and safety of insertion of iGel and AirQ were comparable, where the total insertion success rate and first attempt success rate were non-significantly different between both the types. However, iGel superseded AirQ for significantly shorter insertion time. Maybe it may be attributed to its manufacturing characteristic, which is a gel-like cuff. So it is a cuffless device which do not require cuff inflation, which may shorten the insertion time. Moreover, the insertion of iGel does not need laryngoscope, and thus iGel can be used as a useful tool in an emergency situation where even trainee and junior anesthetist can use. These are the points in favor that studies finding with the Siddiqui et al., who in non-comparative study reported iGel is a simple and easy to use with a success rate of insertion at first attempt of 92% within a short insertion time. With Kim et al. Also found comparative study with the AirQ that iGel is better than AirQ for insertion variables in pediatric anesthesia. On the contrary to above obtained result, the insertion variables, the Ann et al. In comparative meta-analysis found that iGel can be inserted more quickly than supraglottic airway devices except AirQ and LMA Supreme devices. Similarly, Raza and Khan reported higher success rate of blind tracheal intubation with AirQ than iGel. Masudi et al. Showed mean insertion time and number of insertion attempts were significantly lower with AirQ than iGel in general anesthesia with muscle relaxation. But these studies, in these trials, adult patients with verified constitutional factors were being used and studied, and there was use of muscle relaxant. So that may contribute to the controversy. Similarly, in support of the study, Lee et al. In recent meta-analysis showed no significant statistical difference between the insertion variable of iGel and AirQ in geriatric patients, which is also a fragile category like pediatric patients. In addition, Mehra et al. And Hoor et al. In comparison with iGel with Oragen, again show iGel insertion was significantly shorter and device insertion was significantly easier with iGel. In studying with the fiber optic grading of the laryngeal view and tidal volume loss, measures were also evident in literature, where the current study showed non-significant difference. Mihara et al. And Hoor et al. Also showed the similar non-significant difference in iGel and Oragen regarding fiber optic view and leak pressures. Key metal found fiber optic view was better with Oragen, but orolaryngeal pressure, leak pressure was higher with iGel. But Lee et al. Found fiber optic view grading was non-significant between the iGel and AirQ, while leak pressure was significantly higher with iGel. Also, Kohli et al. Studied iGel with for endotracheal intubation in terms of adequacy of ventilation. They found it is comparable to endotracheal intubation, and also there is a without much increase in the peak airway pressures. In similar comparative study, Abdel Ghaffar et al. Compared performance of LMA Classic, AirQ, and iGel at different head and neck positions. Found that in comparison with the neutral position, maximum neck flexion significantly increased leak pressure and compromised the ventilation. But extension and lateral rotation decreased leak pressure mildly with mild effect on ventilation parameters. But in this study, they found that iGel had a supraglottic airway device at different positions and throughout the operative period exhibited best ventilation parameter and fiber optic view grade. So this is again the same chart. Intraoperative hemodynamic changes and oxygen saturation changes showed non-significant difference between both the device, while perioperative complication were non-significantly better with AirQ. These are in comparison with the iGel and endotracheal intubation, Kohli et al. LMA, iGel and LMA Classic, LMA Supreme mega study conducted by Kohli et al., Lee et al., and Ethet et al. Showed non-significant difference in hemodynamic variables and postoperative complication except nausea, vomiting, which was significantly higher with LMA. Gastric inflation was significantly less frequent with iGel than with both LMA and LMA Supreme. And also Mehra et al. Showed lower incidence of device blood staining with iGel. Masudi et al. Reported significantly higher incidence of sore throat, but non-significant difference between the postoperative complication with iGel than AirQ. So my conclusion is no supraglottic airway is immune against defaults, but both AirQ and iGel provided advantages for pediatric anesthesia during short surgical procedures with non-significant differences. However, iGel required shorter insertion time with a higher success rate, which is satisfactory for trainees and during emergency, secondary to its inherent manufacturer character, that is thermoplastic elastomer. It allowed minimization of tidal volume leak, gastric inflation, so it spares need for insertion of gastric tube. Moreover, iGel insertion is associated with infrequent post-insertion complications, so its application is to the greater extent safe. Limitation I found in the study, ideally a long-term study or a larger sample size will make the results more justifiable. Children below 3 years, which we are more concerned about many times, especially infants, neonatal age group, which pose many challenges, studies need to be generalized over all the pediatric age group. Risk assessment in laparoscopic surgery, emergency surgery with adequate fasting, inadequate fasting need to be studied and mentioned separately. Head positioning while supraglottic airway device insertion was not described in the study. Also, any manipulation while inserting the device is not disclosed in the study article. How cuff pressure is measured, they have not mentioned. And fasting guidelines given to the patients were not mentioned. So nausea, vomiting, the postoperative complication may be related to this. Post-extubation period being crucial, in supraglottic airways, they have not given details about post-operative monitoring, how they have done, whether they have done or not. These are the references for my study article. From my point of view, all supraglottic airways for pediatric patients are very helpful, except excellent alternative for control of airway, considering the risk of laryngospasm and bronchospasm being least compared to endotracheal intubation. Learning curve is quick with higher success rate, make their use judicial for newcomers and emergency department staff, even in case of difficult airways. As per the study, iGel show advantages of quick insertion time, effective ventilation, faster learning curve, better fiber optic laryngeal view, and higher success rate over AirQ, making it superior for even a fragile air group like pediatric, geriatric. AirQ, a newer novel device being comparable in many aspects to iGel, is preferable in setting of suspected difficult airway or when prolonged surgery is expected and shift over from LMA to intubation may be required. So I think both the devices are in their way are helpful. Thank you.
Excellent deliberation by the presenters. And Mayuresh has rightly said that iGel and AQ, the success rate with both of them is non-significant, but with the insertion time, iGel is better. And even fiber optic view, it was non-significant, so comparable. And hemodynamic and post-operative complications are also almost negligible in both. Now we have mentors with us, Dr. Sonali Saraf. We have an expert, Dr. Vasanta, and we have Dr. Suma Ganesh. So they will help us to put up their views and comments on today's presentation. I welcome the mentors. Dr. Sonali.
Thank you. Hi.
Yeah, hi.
Welcome all.
Excellent presentation, Shweta, Mayuresh, Sachin.
Thank you, ma'am.
Very nice.
Thank you, ma'am.
I found that I had to read up about this new, airway device
Airway.
around the block.
Yeah.
Even when you showed us this article as a reference, even I had to read through it. So I also learned something new. It's a two-way process. So this is the help. I mean, this is how the Journal Club helps us
Yeah.
as to
Yes.
know, what is around the block. I mean, commendable, Shweta, your presentation was fantastic. Mayuresh, you went through the article very nicely.
Yeah. Thank you, ma'am.
Madam, there is one question which the audience have asked, that how do I confirm the LMA placement without the help of an sonography or a fiber optic laryngoscope, only by the clinical test? So this is a basic question. So I think
So how do we usually do? Not all of us have a confirmation of a fiber optic bronchoscope at hand.
yeah.
Fiber optic bronchoscope is in this study, it was especially useful because it gave the position of the epiglottis and the degree of obstruction, especially because in neonates or in pediatric age group, the epiglottis is a little longer than in adults and a bit more overhanging. So anatomically, they are different as compared to adults. But here is what we do in adults. Fairly, we go by the amount of what is the weight of the patient. So selection of the LME depends on the weight of the patient generally.
Yeah.
Secondly, mouth opening of the patient and the amount of subcutaneous tissue or the fat that is there in the the hypoglossal muscles, the pharyngeal muscles, which can hold the LMA together, is measured. The other thing, other way of doing it is when we are inserting an LMA, it is better to have all the loss of airway reflexes. And propofol is an excellent agent that enables us to do that. So the loss of our oral or oropharyngeal reflexes helps us insert the laryngeal mask without providing a muscle relaxant. So there are 2 or 3 things in this. If we have the proper weight of the patient with us, we inflate it to the right size. Which is quantifiable or which is given in the information of the laryngeal mask. And if we give a gentle ventilation, then we are able to see the chest rise and fall. Now, the thing is whether it provides an adequate seal around your glottic aperture or not, or whether there is any gastric insufflation. That you can know if there is a loss of tidal volume at any point, there is an audible leak at any point happening, or there is visible gastric insufflation happening at that point. So this is how we go by clinically. And
also even the capnograph will show the tracing.
Capnograph will show the tracing, but if it is partially placed at the glottic opening and the esophageal opening, and there is a partial leak into the esophagus, still the capnograph may show, but the leak may be still audible, or there will be other indicators like loss of your tidal volume happening, visual gastric insufflation happening. Then these are the indicators. If the set tidal volume on your ventilator, if the is not coming out as an exhaled parameter, that we will be able to know if we are measuring the exhaled tidal volume as well.
Yeah, other obvious this thing is that your LMA is a very forgiving device. In spite of getting a good ETCO2, good A, it can be in a malposition place. So you have to remember that though to intubate, insert an SGD, there can be subtle gastric insufflation happening if it is malpositioned. So what you see is first oral cavity, whether it is properly placed, whether you can see the cuff. So it's not obviously placed proper. Then the tab, the center, incisors should be in the center. And they have this integrated mouth bite or the tab that should be in alignment with the incisors. So that is the center. So it's not rotated inside. Then for the correct clinical A, you can, if it's a second generation, you can do the gel bob test,
Yeah, it just pops up.
gel bob test, or infant feeding catheter or an RT can be passed, which goes very easily. That is one more thing, the tip is in alignment and the tip is not folded on itself.
Right.
So these are a few things which is an indicator that your LMA is
Rightly placed.
rightly placed. Because if you ventilate an LMA which is not rightly placed, it can lead to massive gastric insufflation.
Yes.
And you can get initial ETCO2, but later on it can lead to,
Yeah.
Okay.
Yeah, but there's one more question. How to measure the LMA cuff pressure if you don't have a proper gadget to measure it? So, because we have to maintain a seal pressure between.
I mean, the volumes are generally recommended by the company.
By the company,
they are
yeah.
given. Yeah.
Yeah.
So do not exceed that volume at any point in time. See, we can get away with oversizing an laryngeal mask airway and underfilling the cuff, or sometimes we do this jugglery, like we feel that the patient's mouth opening is good and will still require a good seal, then we may oversize the device, but underfill the cuff. The basic this thing is that it should sit in the proper position. So as plus the cuff overinflation can lead to a lot of problems like ischemia of the surrounding tissues and severe throat ache later on. So there are reports about the nerve palsies as well, which are reported in literature. So better to avoid that. So overfilling is definite no. Then you may have to resize or reinsert with a other size. I mean, that is how I would go about it.
Okay.
Little leak is preferable rather than overinflation. Yeah.
Because we want it to be distended and not more inflation.
See, one has to remember that the leak, what Mayuresh has also mentioned, leak is different with different types, igel or plastic, I mean non-silicon way, which has crevices, it causes more leak. So that is how you try to inflate the cuff. But the leak test is different for a spontaneous, for a controlled, for same patient using different SGD. So you have to categorize, you have to understand that the leak can happen in the same patient in different conditions. Okay.
Yes.
So there is a method of leak test also.
Yes. So we'll also like to have a general consensus on the LMA, whether LMA should be used for neonatal resuscitation. Neonatal. So what is your... because there is a misconception that LMAs cannot be used for children weighing below 5 kg and in neonates because of its easily it can get misplaced and gastric distension will further impede. So what is your...
We have been using it regularly.
Yeah, even I feel.
And generally we don't inflate the cuff. And the initial, unless it's hugely meconium or something where we cannot aspirate through the air, but now you get Supreme for neonate also. So an uninflated cuff works very well for resuscitation, and especially so when in suburbs and saying you don't have a pediatrician or an anesthetist always in normal delivery or something. The staff manage them very well. The initial part till the help comes.
There is one question while inserting the LMA in a patient, child who is having hypertrophic tonsils or adenoids. So what should be the method of insertion of your LMA?
We have to be extremely careful.
And
I mean, this is where we can end up injuring,
you can use laryngoscope.
Or you can use the
Yeah.
LMA lateral to the tongue and then rotate it.
Very difficult in hypertrophic
very-
tonsils,
yeah.
madam.
You
Yeah.
can
No, no,
use
no, don't do that.
laryngoscope.
Mm.
Laryngoscopic
Under vision.
insertion of LMA is one of the methods mentioned.
Yes.
So you can use laryngoscope. It's nothing to be ashamed of. People think it is a insertion failure. No, laryngoscope has been described. Laryngoscopic method is been described. So in such patients, what happens with hypertrophic tonsils is the whole part of your base of tongue, your part where the soft palate and hard palate is meeting, and the tonsil, everything is at the
Yes,
same junction.
Same place, yeah.
So it is better you flatten the primary curve. By using a laryngoscope, you remove the tongue curvature and place the LMA, so nothing is injured.
Okay. And in a case of an emergency where you cannot ventilate and cannot intubate in a pediatric case, then which supraglottic device would one choose?
I mean, the supraglottic device, I
If
mean,
you have to
all
use
of them
because-
are a part of the,
Yeah.
resuscitation
Resuscitation
training.
training,
Yeah.
Yeah.
In fact, they have been introduced in the basic life support as well.
Yes,
So,
no.
whichever is
Whichever is
available.
available. Yeah,
Yeah.
right. Correct.
Okay, and then, madam, which device one choose if the surgery is going to extend for more than 2 hours in a pediatric
Generally,
case?
this thing has gone, the focus has gone away from using the first
Integrated.
generation now towards the second generation
Hmm.
airway devices. The reason is they are doubly reinforced, have obvious, advantages over the first generation. So, I mean, they can be managed. The surgical cases can be managed easily, and with a reinforcement with a gastric channel, we can
Yeah.
use it for a longer period of
Longer
time.
period of
So now all second generation airway devices have taken over the first generation devices in that aspect.
And there's one more question, madam. Can we do the control mode of ventilation in a pediatric age group using supraglottic device without a muscle relaxant? Is it justified?
Yeah, we can.
We can.
Yeah.
Hmm.
In
Okay.
pediatric age group, so the advantage of supraglottic airway devices, we can allow them to breathe spontaneously as well as give controlled ventilation. So if along with muscle relaxants also, it can be used in a controlled mode when the patient is coming out, is attempting. In fact, we would gradually transition them, allow them to breathe spontaneously, wean them off before reversing as well, and then allow them to breathe spontaneously, waken them up, or extubate deep, whatever is the thing, plan of extubation that we have planned. So laryngeal mask airways are that way quite useful in helping us do all this maneuvering. And for pediatric age group, controlling the ventilation is not a
a big
difficult
problem.
this thing. We deepen the plane of anesthesia using sevoflurane or using propofol, and we are able to control the ventilation without the use of muscle relaxant.
There is one question from Sandhya Nair that is it mandatory to use gastric insertion Riles tube with every supraglottic device? So I think
not
until and
necessary.
unless, yeah, it's not necessary. Then,
But if there are tricks too, because once you have inserted the supraglottic airway device and then you want to pass an Riles tube through it, then it may be a bit difficult because of the curvatures.
yeah.
So there are tricks to insert if you're planning to use a Riles tube through the supraglottic airway device, then you need to be prepared before, lubricate the channel, pass the Riles tube till the tip, keep it there so that you can easily proceed. Otherwise, you will often find it difficult, even though the channel is there, to pass a Riles tube after you have, in between the anesthesia part of it.
In between the
Same
surgery.
Kala, Dr. Bhatt is also there with us.
Yeah,
so.
even Soma Ganesh is there with us.
Soma, yeah.
Yeah, so it is better to plan our Riles tube insertion beforehand, before the surgery starts, so that we can save on that. Then, how long can we maintain our anesthesia on iGel supraglottic device? How long can we continue to do on only iGel?
I mean, in my opinion, generally surgery is lasting for 2 to 3 hours. We have done successfully. But
Okay.
then I'm sure others would also, Dr. Bhatt, he has extensively used the
Yes,
supraglottic airway.
yeah, he has. Yes, Dr. Yogen Bhatt. So you have to unmute yourself. Huh?
I end up using for 5-6 hours in cosmetic cases,
Yeah.
Yes, sir.
but that is because they take time. By and large, I avoid, but I still use them.
Yeah.
Lap cases only once because I had not been able to intubate because the patient had some node in front of the larynx once, a big one, and I just could not see the glottis. And I had no option. I told the surgeon that if I'm not able to manage with my laryngeal mask, then I'm going to come out.
Yes, right.
Now I could ventilate the patient nicely, capno was coming nice, everything was coming nice. So we went ahead for about 3.5 hours on that.
Oh.
Later the surgeon said, yes, I remember patient had told me I have some growth inside the throat and all those things, you know. So, but as Madam said, Dr. Saraf said, probably 2.5 to 3 hours is an outer margin, because as the gas would expand with the body temperature, the pressure will go up, and we do not have the habit of relieving that pressure every half an hour. We have to cultivate that habit, including the endotracheal tube cuff. We have to be taught that way, that after half an hour, the air or gases which are there inside, inserted at body at AC temperature of OT, when they find the inside temperature 37, they always go up. And about an hour's time, if you have a pressure meter, if you find out the pressure is always gone up. So we have to develop that habit. After 1 hour, start deflating a little more. And in 2 hours, probably don't require more inside the cuff because the tissue edema has taken place and it has gripped the tube. Same thing happens with LMA also. You don't have to push much air. That air expands and you better keep on removing that air.
There's one more question, sir. When you are past your LMA under deep anesthesia without a muscle relaxant, what are the chances of getting laryngospasm? You are not used muscle relaxant, only on inhalation or TIVA technique.
See, gag reflex is bound to come. Gag reflex because you are going to stimulate the larynx, which is which has the maximum reflex is gag reflex.
Yes.
You are a patient in tetany, they respond to gag reflex. So best is to take them deeper or little more deep, give 3 ml more propofol and then give. In that case,
You can prevent the laryngospasm.
Laryngospasm has never bothered me, no. I had to give relaxant because of laryngospasm. That has never happened, no.
Yeah, there's one question from Harsha Bhatia. She wants to know how should the supraglottic device be fixed? The technique of fixing she was wanting to know.
There are many techniques mentioned, and I do not follow any. So it is not going to go inside and migrate on one side. It is not going to come out. It is so big. So best is not to fix, but there are people who take that U-shaped dressing and these and that. There are many slides available on that, but I have skipped that slide in mine because I never do that.
You have to fix, you fix it to the immobile part of your
Upper
face.
part of nose and all.
Upper part
Maxillary
rather than the lower part.
Maxillary part. Yes.
So that it is snugly fitting.
If at all, but I have never done that. It doesn't go inside, doesn't come outside. So then why worry about it?
There's one question from Madhuri Shekokar saying that are there any chance to get bleeding while putting an eye gel or any other supraglottic? Yes, of course. So I think Mayuresh has already answered in his article. We have Soma Ganesh also with us. His views and comments. Yes, Dr. Soma Ganesh.
Yeah, am I audible? Yeah.
Regarding
fixation, I find it pretty useful to fix it at the maxilla rather than manually. So as everyone pointed out, because that helps in keeping the. In fact, if you fix the supraglottic device at the maxilla and then keep the circuit at the free falling at the midline. It just
Okay.
keeps the seal also adequately. So we don't have to worry about anything else, so that whether the supraglottic device will dislodge or something like that. I use extensively iGel and LME Supreme. So I found this very useful. And second thing is, someone asked about the how to confirm the whether the LMA is in place or not, or whether we are able to. It's pretty when there are no ultrasound or any other stuff. Of course, we don't. Even people who have access to ultrasound, they don't regularly check the placement of LMA using ultrasound. It's all clinical, whether how the chest rises and auscultation when there is no inflation of stomach, and the inspiratory and expiratory tidal volumes, whether they are matching, maybe a 50 ml or plus or minus, that shouldn't be that should be okay. So apart from that, if we are using specific supraglottic devices, then we can have specific tests for each and every supraglottic devices. For example, we have ProSeal, we have this Bremacum bounce where you keep a gel at the drain tube and then you press at the suprasternal notch and see whether it is there or not. If we are using a second generation supraglottic device, it is advisable to use to put a drain tube so that the drain tube passes into the esophagus, and that indirectly helps us in giving a proper seal against the laryngeal inlet so that your ventilation or any other issues will not be a problem.
So there's one more question. If you are not remembering the table of the manufacturer who gives for the supraglottic, the sizes, so what is the other crude method where you can, say that this size will fit for the pediatric patient? Yeah.
There is an crude method, the size of the pinna. So the supraglottic device, the shape of the cuff, it should match the size of the pinna, then that will usually fit in properly. That's what they say. But usually we can, I think we're all experienced clinicians, even second year or third year postgraduates, they will easily will say, oh, this patient is around 40, 50, 50, 60 kgs, a 3-size iGel should fit and all. So clinically, we can easily gauge and judge. Just like endotracheal tube, it's very easy to.
They also say if you can see these 3 fingers, the index, the ring, and the middle, the thickness of that.
Yeah.
So difficult not to. It's written everywhere, even on the laryngeal mass. And the cuff volume is also written on that.
Everything is written.
So they have literally spoon fed us, so that we don't forget. It's very good. We don't miss out.
Yes. Just wanted to complete that list. Anybody wants to add more on this presentation? The experts and the mentors.
We can continue with the videos, madam.
Okay. So now the most awaited session of how I do the video session. We have 2 experts with us, Dr. Yogen Bhatt and Dr. Namazi. I take this privilege on behalf of ISA Kalyan to introduce Dr. Yogen Bhatt. Mayush, can you put up the slide? The president of ISA Borivali. He has a vast experience of 42 years in private practice of anesthesia. He is attached to the Department of Anesthesia, Shatabdi and Bhagwati Hospital, and also attached to Namha Hospital and Vardhan Hospital. Also a recipient of National Proficiency Award, ISA, in 2015, and National Award for the calls in 2021. Today, sir is going to share fascinating videos from his Pandora box. We welcome you, sir. And I request everyone to give your full attention to Dr. Yogen Bhatt. Yes,
Welcome,
sir, you can start sharing.
Welcome, sir.
You can start sharing.
Yes,
Yes,
sir.
Share. Yeah, I'm there on the screen now.
Yes, yes,
Yes,
yes.
sir.
We
Yes,
can
sir.
see.
Yeah, fine. I'm not going to speak about how to insert an LMA or how to insert the CLMA, because that era is gone. I'm now going to speak little ahead of what we see. Mine is a registered company under the Plexus Anesthesia Solutions, and there's a family. What is required? A change of mindset is needed. Everywhere you can listen to this talk, and if you ask an anesthetist, no, we don't use it. We are afraid of aspiration and this and that. And that Macintosh Baba, which has been stuck in your brain, in the middle of the brain, was hammered down like Jesus Christ. The Macintosh study that was conducted in 1953, 1947 to 1950, that was before I was born. And when ether was the main agent and black colored mask was the thing. And in 6 years, they had found 6 patients who went in Mendelssohn syndrome. But the way it is hammered in our mind, we just are not able to come out of that mindset. I don't say that I have not seen Mendelssohn. I have seen 4, and all 4 of them were under spinal anesthesia. So we'll go to the next one. Why? What is holding it up? Our own minds are holding it up. It's all there in the head. We are not trying to change. We are not trying to think what is there tomorrow. We all know this story. Probably the one with the straw is the next generation that I'm going to get. This is just a simple video of demonstration.
The hard and then the soft palate of the patient to perform a sweeping action.
As you see, this is being pushed inside, and the direction is you have to put it upwards over the palate, etc., etc., and then fix it up down.
So slideshow is not
Yeah,
started.
yeah. We cannot see your videos.
So I'm able to see.
No,
No,
sir,
sir.
we cannot. We can just.
Oh, okay. I thought I am seeing all that, so you all must be
No,
seeing.
no, no.
No, no.
No, sorry, slideshow is not started.
So stop
Not
the
started.
share and tap on the share 2 times. Double tap.
Double tap here. We have opened the same.
Yeah.
Oh my God, it will eat away my ROM capacity. It will get held up. See, it is already getting held up now.
No, it is not stopped sharing.
Okay, stop share किया मैंने.
Yeah, yeah.
Right, now I
Yeah.
share screen.
Double tap there at the share option
Double tap share option. Okay,
on the box.
and the box. Okay. Now this is there on the screen.
Yeah.
No, not yet, sir.
Not yet. I can see it on my screen. Or resume.
Slideshow is not started, sir. Just the first slide is seen.
Yeah, only your slide is in, sir.
First
time.
slide is seen.
Yeah.
Yeah.
Okay.
Can
Second
you,
is come.
sir, can you please stop the slideshow totally? Stop slideshow.
It is actually resume show करके आ रहा है.
नहीं सर, after you stop that slideshow ना, right side पे lower corner पे blue color का सिर्फ share है. That you are supposed to double click.
One second, let me just see. Okay.
Go in the green share screen.
Right side का सबसे
Okay.
lower corner. Double click that.
Okay, मेरा center में है share screen. I will double click.
That you start and after that you will get share option again. That you double tap.
You are able to see that elephant now?
Yes, yes, yes. We can see.
Okay, fine. So probably I'll just go back to my 2 slides. Okay, this is what. Is that? Is it seen?
No,
Yes,
no,
yes.
sir.
Fine.
No, sir. It is not.
Sir,
going.
no.
No, only the
No,
slide
no,
is in.
sir.
The shared
Sir, you
slide
are not
only
in the
seen.
slideshow yet.
Oh, is that so?
Yeah.
My slides are
Because it is
showing.
not the full screen.
Okay, shall I come out?
Yeah.
First slide show निकाल ही देता हूँ मैं ऐसा करके. चलो इसको मैं निकाल दिया. I'll go back to this and zoom. Oh my God. Now why am I not able to see what I want to see? Can someone guide me, please? Why am I totally gone from the screen?
Sir, in the middle there is a share screen.
Share
First
screen.
tap that. Yeah, first
Yeah.
tap that.
Hmm.
Then you will get a box in whichever folders are on your laptop.
And मैंने वो folder बंद किया था, तो I have to first open that folder, no?
Yeah.
Please just bear with me for a little while.
Yes, no problem.
Yes, no problem, sir.
इसमें ये किधर गया? One. Yeah, actually, I had kept it open before we started. So
Yeah.
let's see. It is going to play now. Do I do the slide share button first and then play the slides?
Then sir, share sound and optimize for video clip. Select that also.
Okay.
In the left side. After you start sharing.
Aya?
Only your first slide is seen. So
First is there, no?
Yeah, first is there.
That plexus name has come.
Yes.
Yeah.
And then this, and this baby elephant is seen.
It is not changing.
No.
Right?
No, sir, it is not changing on our side.
So you're not doing double click, I guess, on that one.
Go-
There is a both share option separately. I guess you're not putting a double click over that.
So go in a share screen, green in the middle. Yeah,
Yeah.
in the right side there will be share sound and optimize for video clip. Select dot options.
Yes, there is a share button there. Yes, I press that.
Yeah, I think it is now. Yeah.
Now we can see your slide.
Yes,
Aya?
sir. Yes, sir.
Yeah,
Yes,
the
sir. Now we can
elephant
see.
slide.
Yes, sir.
Let me
Yes,
first.
it is.
I'm sweating now.
Yes, sir. It got started now all.
बहुत काम कराते हैं अपने पास. Fine. So this baby elephant was tied एक जमाने में with a small tree. Now he has grown up to a big mountain. You can hardly see him in the screen. Yet he thinks that he cannot break this tree and he cannot break out.
Yeah.
What is holding you up? This is not possible. It is there in the mind. These are us, and this is my next generation. I want them to be like this, nice and smart like them. Here is just a video of
The hard and then the soft palate of the patient to
company
perform
video.
a sweeping action, vertically or obliquely, brings about simplest method of effective. And there you see it, following the natural curvature, with the finger going as far as it can, and then using the other hand to stabilize and
As you see, it is now entering the esophagus. The teeth is supposed to enter the esophagus only then, and once you inject air, it comes back a little. As you see, it comes back a little. The tip is now blocking the esophagus. It's a classic element, so it is going to block the esophagus. And then you start ventilating, you see the gases going in and out of this. Same thing, I heard a lot about IGL today. I am not actually very fond of IGL because I got many other type. But again, as you see, this is blocking the esophagus part, which has that channel, so it can take out whatever is there. And this opening is right in front of the glottis, so you are able to ventilate the patient nicely. Some of the videos are a little old, so kindly don't get carried away why somebody has not changed. These are almost 15 years back, maybe, you know. And small hospitals, we are still not changing everything. This is RMS Supreme. As you see, it just glides like a tongue depressor. It is not difficult at all. It is an extremely simple thing to do. I showed the slide of Supreme Lma. One day Dr. Kamdar had called me up. Kamdar sir is the founder president of our branch, and he asked me that Yogen, my wife Beena, who was HOD, is trying to explain me how to insert LMA, to put the finger in the notch and then you put it inside the palate and then you go inside like this and this and this. I cannot understand, he said. He said, sir, I told him, sir, kyun dimag kharab karne ka? Why use your finger? Use a laryngoscope. She says, but it is not to be. I said, it is not to be used. यानी ऐसा कोई rule थोड़ी है कि not to be used. You put, instead of finger, you put a laryngoscope. And in 1 hour, he called me, Yogen Baba ki jai. I succeeded in putting my first LMA. You know? So point is, we really get carried away by what is mentioned in the books. You know, But if we simplify, we try and make it practical and simplify, it really becomes simple. Just see, again, it is not a very tricky thing. Just, I don't give muscle relaxant also, just take them little deeper by giving 3-4 ml extra propofol. And then it's not a very difficult job. Just push it in, wriggle it up a little if it is not going beyond the tongue. Remember, the new brand of LMA that has come after Teleflex has taken over, it does damage the palate. I have almost given up on this brand. I am not very happy with that because it does damage. I think it's a little too slow playing. I'll go to the next one. This is the new LMA in market. It's a new LMA in market. Just see, it is almost manufactured like laryngeal mask Supreme. And done. My job is done. It is as simple as that. It is a second generation. There is one tube here. There is one more tube on this side also. It is manufactured and going to be marketed in next couple of weeks by BPL, or maybe they already started marketing. But this is one of my most favorite. This I think Dr. Jaju had mentioned, Dr. Shweta had mentioned this. Only I wish she had shown a few photographs of this Baska. Baska is a very cute looking transparent thing with 3 lumens in that. Again, it is as simple as what you saw. That is called as Sargent's, the one which was used before. I used to use it for a very long time. I had a brown colored Sargent's before. So it goes again as simple as that. There is one opening over here. There is one opening over here for ice tube if you want, and there is another one drainage there to suck out the sump of the laryngeal mask. This is what I meant when I said, why use your finger and make it more difficult? Why not simply guide it with a laryngoscope? I'm just opening the mouth with the laryngoscope. I am not interested in seeing the glottis. So that it goes in as easily as that, and it is not difficult. So I think we only try to, now look at this one, the same one which I had shown just now. I'm going to that BPL type. It gives us wideish mouth opening. It prevents trauma to the palate. I have observed that none of my patients now get a blood-stained LMA when I'm using a laryngoscope. Dr. Kala had just now mentioned that one of the recommended methods is to use a laryngoscope. You are not interested in seeing. Don't get carried away by what they are saying. You don't need this and that. So it's okay. You don't really need, but it is just to make a nice big opening. Ambu's laryngeal mask, if you have seen, it is little thick. The stem is little thick, it doesn't easily enter. So you require something to open it a little wide, or you require extra propofol. If a patient is hypertensive, taking antihypertensives and other things, then that extra propofol may unnecessarily give some fall of BP. So I try and avoid that. Stopped in the middle actually playing. So if you see now, we have inserted the laryngoscope and making an extra room for that element to insert inside. We are not interested in trying to see what is there inside and all, but it gives you an extra room for insertion, because Laryngeal mask of Ambu is little thick thing over there. It does give difficulty in insertion. Otherwise, structure-wise, it is very good. It also has a bridge if you want to insert an endotracheal tube through that. Our conventional endotracheal tube also enters that, and if required, you can do an intubation also. Rise tube, whether it is required or not. Just see the amount of a Nilvai mouth patient, young lady, just see how much can come out. So, an LMA is given a drain tube, please use drain tube. I usually use only a suction catheter inside. I am not interested in putting a rise tube. Rise tube somehow is packed in such a way that it gets folded at the wrong place and then it keeps getting coiled in the mouth.
So which number suction catheter?
Orange colored 16 number goes very nicely inside. If it doesn't go, you have to go a little thinner, but that, so invariably, even for my laparoscopic work, I never put a rise tube. I just put a oral suction catheter. It goes inside the stomach and does drain out everything. Now there is something called as Bailey's maneuver. I don't know how many members are using it. In Bailey's maneuver, what we do, this is a patient for bariatric surgery, and it is very difficult to ventilate them and hold the mask ventilation. And as it is, we are not nowadays using
face mask.
Colin. So instead of struggling for holding the face mask and all those things, just simply after taking the patient deep in anesthesia, I connect this and I just simply switch on the ventilator. After the ventilator starts, I give some muscle relaxant. Then I finish my other things. I keep my laryngoscope ready and all those things. And then after 3 or 4 minutes, the patient is nicely relaxed. I go and intubate that patient. Till then, I am not in a hurry to intubate a patient. So the ventilation part is initially done by this laryngeal mask. The biggest thing is, if you are able to ventilate after putting the laryngeal mask, that means your fear of CICV is gone. Can't intubate, can't ventilate is gone now. Now you are not bothered. Let it take 3 minutes more. कौन सा surgeon अपने लिए fast surgery करता है? Let him wait for 2 minutes more. It's okay. So we started that way. Of course, this is, and then a simple king vision is inserted, and you can see the endotracheal tube. So after 3 or 4 minutes pause, I then go and intubate a patient. Another patient also, if you want to see. Yes. You can just put a. So this is actually Bailey's maneuver. That thing was called as reverse Bailey's maneuver. In this Bailey's maneuver, what we are doing, you insert the LMA first, inflate the LMA, then deflate the tube, remove the tube, and simply shift the catheter mount, and then see what happens. You are simply, if that is required for a patient who is extremely obese and you want them to come out slowly off anesthesia. The diaphragm and all that abdominal wall is so thick, it is very difficult to ventilate. So allow them to come out slowly. Or a surgeon doesn't like his hernia patient coughing away after the surgery. So I like to do this, what is known as Bailey's maneuver. The video now stops actually. It's large.
Very nice, sir.
Nobody keeps stopping in between. See, I am just connecting that thing, removed endotracheal tube, and this is connected over here. And if I show the capnogram, after I have trimmed it. But so when you do Bailey's maneuver, it becomes a very simple affair. So now, even if the surgeon takes half an hour more, LMA is not going to give trouble to you. You are able to ventilate that, you can see it also. Also, yes. Half or more than half anesthesia is required for a patient to tolerate the endotracheal tube. The suturing part and all doesn't require that much anesthesia. In fact, at the end of the operation, you press the wound, he has no pain because we have given him sufficient anesthesia and sufficient analgesics. So, better to allow them to come out. Now, see, this is in a obese patient, a real bariatric surgery. That was just a demonstration case. This is a real bariatric surgery patient. Now 120, 150, 212, I have done up to 264 kg. So those patients, the diaphragm gets fatigued. It cannot lift the abdominal. The diaphragm cannot lift the abdominal wall. It gets fatigued. It gets tired. So allow them to slowly land on a laryngeal mass. As you see, the laryngeal mass has gone inside. Now I'll be inflating the cuff. Once the cuff is inflated, then deflate the cuff. So first the cuff is inflated, then the cuff of endotracheal tube is deflated. Then we simply remove that endotracheal tube. Just pull it out and connect the catheter mount. See, now this patient comes out so smoothly. At the end of the operation, all my patients are widest possible awake. This is what I meant. I said I'll be showing a Capno movement also. So you see that you are able to see all parameters. Even at that stage, the parameters cannot be better than this 70 BP pulse rate and this much BP and 35 Capno. It's an excellent way of managing a case. So best is in obese patient, don't allow the diaphragm to get fatigued. Simply switch on to. So this was one part of the slide. I am going to now stop sharing and I'll go on to my part 2 for the slide. Kindly allow me, please guide me again.
Yes.
Shall I open that folder first and then go in this?
Mayuresh, you're mute.
So you can open that folder directly.
Yes, sir. Yes. You can start directly.
I'm going to disconnect. I'll open the next folder. No,
Preeti, you want to ask meanwhile something?
you can ask, please, till I reorganize.
Yeah, Preeti.
She raised her
Hello?
hand to ask a
Yeah.
question. Yeah. Yes, Priti.
No, nothing. It was just by mistake.
Okay, then you can lower it.
Yeah.
Yes, Soma Ganesh had shared something, some view he has shared.
The slide come?
Yes, sir.
Yes.
The slide has come, sir.
So I go to the next part of the slide. I broke my talk into 2 because otherwise the screen gets jammed, you know.
Yeah.
Yes. Yeah, we can see the.
Yes, sir. Yes, sir.
Now this is called as blockbuster.
Yeah.
Torrent is inserted in LMA called as blockbuster, and it has an advantage of the first 1 or 2 slides because the videos are still loading. It may go a little slow, so please. So the blockbuster LMA is already inside, and now I am putting an endotracheal tube inside that blockbuster LMA. Sorry. You see, I wanted to have a look at the tip of this blockbuster endotracheal tube. It is shaped like a cobra. As you see, it goes anteriorly. I'll show the photograph after this. So all our endotracheal tubes are manufactured in such a way that they somehow enter posteriorly. You know, the packing is such that it always goes posteriorly, but this always goes anterior. It is shaped like a snake, a cobra. So it enters anteriorly. Unlike our normal Portex tube is designed and packed in such a way that it is by default enters the esophagus only. Here's another case. I think that's the same one. I'll go for the next one. There's another. Little issue with the slides, but if you see, it's entering nicely. I guess it's the same patient. Maybe it is playing only half. I don't know why. Yeah, but she has managed to push it inside. It is not downloading fully. I don't know why.
Maybe some limit is there. Don't know.
If I keep on doing it, it just keeps coming, but then it will get.
I can see BIS monitoring, sir.
Yeah, BIS monitor is being.
You can see, yeah, that you could see that. Yes. Forget it. This is also a blockbuster. Let me see, maybe this will play a little better. Maybe hope so. Is it playing? Not playing. That's the blockbuster. It has a bridge inside the cuff, inside the sump in such a way. The bridge is shaped in such a way that when you insert an endotracheal tube, it pushes the endotracheal tube anteriorly. And when it goes anteriorly, as it is the shape of the tube is that shape of a nagoba, as I said. So it manages to enter the larynx very easily.
It's that Parker pen flex tip.
Yeah, the tip. I'll show the next slide is the
The
tip.
others are pencil tip, and this is Parker pen flex tip.
Inside. Now we just have to remove the LM and fix it. That's all. Where is it? It doesn't play fully, gets fatigued. I think. See, we are just pushing that tube inside. Managed to connect it, and of course Capno will be able to show, but I'm not going to waste my time showing the Capno, but I have been able to intubate it very nicely. So this is what I was trying to say. The tip, as you see, is like a snake, look at this tip. So it always goes anteriorly, and now that there is a bridge inside the sump of the laryngeal mask, it pushes the tube little more anteriorly, and it easily enters the larynx. Again, this is that reverse Bailey's which I was saying, whereby you insert an LMA first. Look at these obese patients; they are a little too difficult to ventilate, hand ventilate. The larynx is anterior, and it's not easy to ventilate them. At least when you are not giving scolin, it takes 3-4 minutes. And I usually prefer to use C-cetracurium. That takes easy 4 minutes. For C-cetracurium, you have to give additional dose of propofol, otherwise they come out of propofol. Look at this. And since I'm not going to project how laryngeal mass, how endotracheal tube works, how video laryngoscope works, but you can still have a look. It becomes a cakewalk once you do that. All my videos stopping at that level, actually, somehow. You can see the ventilation started over there.
Yes, sir.
I'll just jump to the next one. Again, same thing. We'll not continue doing the same thing now. This also is similar type of thing. This is something to be seen. It belongs to Dr. Vivek Gupta. Not my video, of course, but sir has given me permission to share it with you all, just for ease, just for convenience sake. What he uses is a shoe spatula.
Oh,
The tongue down, like I was using laryngoscopy, he's using a shoe spatula.
very innovative.
He just makes room for the
LMA too.
region.
Yeah.
He just walked in easily.
LMA.
We could not see it that clearly, but the point is, all is to just shift that tongue a little more, create little extra room for our LMA. Only then it will not traumatize the palate.
Yeah.
If a palate gets traumatized, now it's a very bad experience. It is not a very pleasant thing. They get pain for days together. My slides are getting hung up. I told you it's a big folder, na, so they take little time. When you have so many videos, it gets hung up. Stop it and clear again. If I press that play button couple of times, it will get hung up. Mhm. Yeah, yes. You all know this
Video learning.
Medicam video learning. That also is very good for, especially for a beginner. It definitely is good, and for practically everybody, it is not a difficult. The only difference is that it is nothing but a Macintosh with a camera mounted. So if Macintosh is not going to help, this is also not going to help.
Correct.
This is again that reverse Baileys which I was saying. Supreme Lma. This of course is my brand, as you all know.
Yeah.
When I show this video, everyone asks me कि तुम ये सब circus क्यों करते हो? I'll show you why I do that. You have to actually push that shoulder down to create more room for the laryngeal mass to enter. This patient is inserted in prone position. These are all my cosmetic surgery patients, and in that hospital we have just one staff member because they don't want anyone to know that they were undergone cosmetic surgery. The patient wants to know. So that it just walks in like a tongue depressor. It's not a big thing if you see.
Yeah, very beautiful, sir.
Worried whether patient will vomit. If vomit करें तो नीचे जाएगा. Upwards and backwards trachea में थोड़ी जाने वाला. It is going to go outside. Even if they vomit, suppose by any chance. And I never give relaxant before I push this. I give my relaxant afterwards.
Okay.
These are all cosmetic surgery patients. They don't really require relaxant. I just give 2 or 3 ml of atracurium, and that is sufficient practically for the whole surgery once they are on ventilator.
So you use sevoflurane in that case with Attrac?
It depends what I am going to face. There's CO and ISO in reality, unless you are going to use it as an induction agent, they all same.
Yeah.
So yeah, the difference. We have grown from ether to trilene to fluothen to isoflurane, now sevoflurane. Desflurane bhi aayega. We'll keep growing with that. Point is, it is very easy to insert. Question is why to insert?
Able to ventilate in prone. So put your hand from underneath like this, as a cup. Able to ventilate like this? Very nice. Lovely. That's good.
It's the same BPL thing. That also walks in equally easily. All you require is just lift up the head slightly upwards like this, put this one shoulder downwards, create room for the laryngeal mass to go inside, and that is sufficient. It does it. This patient is not relaxed, and this BPL Lma is slightly on the bulkier side, so that doesn't go very easily. And this was the first time we had done in prone position with that. Off late, I am not doing in prone position because now I am not in the same hospital anymore where the staff is less. I'll show you why. People ask me why I do all this thing. Just see how many people are required to turn one spine patient prone. 1, 2, 3, 4, 5, 6, 7, 8, 9, and that fellow 10. 10 people, 10 muscular people, ward boys were there. It's a spine surgery and orthopedicians are also strong, and their patients are also strong. Everything is strong over there. But look at this cosmetic center where I work. Start doing head count. 1, 2, 3, 4, 5. There were 12 people in the operation theatre to turn one patient prone. The center where I was working, Priyanka Chopra Center, there was to be one ward boy. See, the driver also is coming to turn the patient prone. Point is, these patients don't want people to know that they have undergone surgery. So that is the reason why we used to. Off late, I have not been doing it much, but I want all of you to learn this practice once. When a friend of yours is there, please try and learn this, because कभी एक PCNL करते करते उसको time लग गया, he broke something, or your spinal fell short, then at least you will be able to give GA comfortably. Number one. Number two, Irene Osborne. She had presented a case where the resident came and he changed the sevoflurane. He filled the sevoflurane vaporizer and he forgot to switch on the sevoflurane.
Yeah.
Under the drapes, that spine patient woke up, started looking and calling the surgeon, "Hey, what's happening?" And because the hand was on the endotracheal tube, when she lifted the head, the tube came out and she started talking. And the surgeon started screaming. Patient was not getting pain. So Irene Osborne said, "Yo, just shut up." And then she held the sevoflurane mask and inserted one LMA Classic. She has a lovely video of that. Only she said, "I can't show you that video because it is a teaching institution." But whenever this happens ever in your life, this is one thing you can do that. So please try and learn something different.
Yes.
Yeah, surely.
This is latest in the market.
Airway. The hot color is the area.
This is an endoscopy LMA. Nowadays, everyone wants to do bronchoscopy, endoscopy, gastroscopy, ERCPs and all. And we find it very difficult. At times, we want to give G. And if you put endotracheal tube, the scope keeps on removing our tube. So both are rubber, though it keeps on pulling it out. But when you have inserted this kind of laryngeal mask, which has a nice opening, which is tested by putting a jelly already in that. So now he is able to put the gastroscope inside that, and the screen is seen nicely, and he is able to finish his ERCP.
Yeah.
Thank you very much. This is my team. Thanks to all of them that I am able to do that, and thanks to this lower team which is always involved in photography. Doing a case is one thing and recording it is another thing.
Yeah.
Yes,
Definitely.
I know.
If you are not able to record, you can never present it.
That
So
is
my
it.
result
Yes.
has additional team created with you. Thank you very much. Thanks a lot. I just presented things which are little newer and not the old ones.
Yeah. Thank you so much, sir, for your great
Excellent.
videos and showcasing the difference, all different type of supraglottic devices, great videos and perfect
Yes.
demonstration and explanation. Now we come to our next esteemed guest in our How I Do It video session, Dr. Ismail Namazi. Mayuresh, can you share that slide of his CV?
Yes.
Yeah, it's absolute pleasure to have you, sir, with us today evening. He has vast teaching experience of 30 years. He's professor, HOD since 15 years in RCSM, Government Medical College, Kolhapur, and DY Patil Medical College. He has been internal and external examiners for his students and has conducted many workshops and conferences. He celebrated the World Day Anesthesia on 16th October by writing an one-act play. He has many publications to his credit, at state and national level. He's ex-member of Academic Council Board of Studies at DY Patil University, Kolhapur, and he is past honorary secretary and president of City ISA branch, Kolhapur. So friends, sit back to watch sir showing an excellent video of intubation in prone position through the supraglottic airway. Sir, over to you.
Hello, am I visible and audible, madam?
So you are audible, but you have to share your screen. We are not able to see you. You have to keep your video on.
Video is not seen. So you are muted.
So we can see your slide.
Yeah.
Yeah.
Yes, sir.
Madam, I'm very thankful to your nice introduction, and very much thankful to Yugen Bhatt sir, who has invited me. Or also, he's also interested in my topic, and my mission of life is to introduce our younger generation how to do the intubation in prone position. He has already shown what is the difficulty in conventional method for prone surgery. Patient 7-8 people required for turn the patient from supine to prone and prone to supine. By doing this, where are the toe of whether the patient get extubated during this maneuver. But I think if you adopt this method, tracheal intubation in prone position directly, without following the, can I audible, madam?
Yes,
Yes, you are audible.
very
sir.
much, sir.
So for last many years, for 7-8 years, so starting at Siliguri, where first I given a speech on the insertion of Lma in prone position. Later on followed by many places at Solapur, at Vadodara, and TMC Bombay, and NAC at the Calcutta also to the 18th, and in Shirdi, I have shown demonstration how to do the prone intubation, Lma insertion. Can I finish? No. This. I presented this NAC Calcutta 2018. So written this one, Calcutta is historical city. Indian history of anesthesia began at this city. First ether administration at Calcutta in 2nd March at the medical college under supervision so and so. First ether administration in Boston, 16th October 1846, and then first administration of chloroform 12th January 1848 maybe, and immediately followed the chloroform in India at Calcutta also. See this case. The first case I had done. This is abscess or neck. It's not possible to intubate the patient in a conventional method. So I had to put him Lma in supine position. This probably very famous article written by Aloka Samantre. How will you anesthetize this patient? There is a knife near the vertebral column, and the surgeon say, don't move the patient. If you move the patient, you're likely to cut the nervous system. And so he strictly warned the anesthetist not to move and give me anesthesia. So in that case, you use the intubating Lma, and he passed the endotracheal tube as surgery occurred. See, similarly, see this, can you see knife in the neck also?
Yeah.
Yes,
Protruding knife?
yes.
I can't see here, but can you see it? So how are you going to intubate? So in this situation, you must have a technique of intubating in prone position only. Suppose we have intubate the patient in conventional method in supine position and then turn to the prone, and accidentally, unfortunately, accident extubation occur. Now, how will you go to manage the further anesthesia? Probably knowing Dolkia in Bombay, very famous story when very rich person, very obese patient, in 1982 or something in this way, and accidental extubation occur. Surgeon started shouting, see that there is dark blood. So they cannot, they have to, that time there are no supraglottic devices and there are no any monitor. So they have to, they take little time to change from prone to supine position. Because there was hypoxia and all those things, cardiac arrest and death occur. If it would have been this supraglottic devices or fiber optic, and he would have survived. So we are lucky. I'm also started my career right from chloroform, ether, and open drafts, and then I come to this level. I'm very happy. So when I see the surgery done in prone position from supine to prone, prone to supine, I really feel this one. I see people, anesthetists should learn the method of directly intubating in prone position. Save a lot of, I'll just show you. See, when there is difficult adventure looking direct laryngoscopy in prone position. So why you feel this as if you are on this and is unable to. So next. So when you give any expedition, you always keep everything ready before you go to avoid the accident. So we have got a lot of instrument nowadays. This was not possible when you use only direct laryngoscopy. You know, for direct laryngoscopy, you need all the three axes should come in well, flexion of neck and Atlantic expert. In prone position, very difficult. So now you have got all these pentox, this is supraglottic, different type of devices, and fiber optic, and we need a special types of table, just called Williams table. You can see the Williams the curvature. You can abdomen get free for excursion abdomen, and the hands are on lower side. Airway management in prone position poses many problems. It is not a usual position for airway management. Option for airway management in prone are direct laryngoscopy or oral intubation, blind nasal intubation, awake fiber intubation, and intubation using a supraglottic devices. Direct laryngoscopy and oral intubation under vision can be done in prone position, but it is poses a lot of challenges, which include difficult position for airway manipulation, limited time. So, you know, instead of describing, the direct laryngoscopy is very difficult in prone position. We cannot achieve the position which we require for intubation. So I have tried also blind nasal intubation also. It's very easy, but you must get expertise, and then you can use blind nasal intubation during prone position also. So why you feel difficult or having inertia for intubation and prone position? Because we are not learned. It's not used in a regular practice. It's not taught to us during our residency. Fear of not achieving adequate ventilation in any odd position. What is the present scenario? The routine practice of prone intubation not done. Only the emergency condition like a stab in thoracic or cervical region, fear of loss of ventilation during a tip, that means tracheal intubation in prone position, can be overcome by adequate training using mannequin. What is my aim and objective? To encourage the anesthesiologist, younger generation, to learn a skin and technique of tracheal intubation in prone position. So shortly, I can tip. You must remember. What is the objective? Anesthesiologist should master tip, able to intubate in prone position when accidental extubation occurs during surgery. That's why the Bhatt sir told regarding PCNL. I also seen that when you do PCNL surgery, anesthesia surgery, it happens that your level is not achieved properly, anesthesia level, or the prolonged surgery, and you have to continue the anesthesia. In that situation, this LMA will be much helpful to you. Unable to intubate patient of stab position. In routine surgery, you know, TAP is not followed because of fear of not achieving the securing airway in time, and maybe to serious problem, even may lead to death. This is our fear. However, this type of problem was possible when direct laryngoscopy was available as a single equipment. So the advances in airway or during last 2-3 decades, like supraglottic devices and fiber optic devices, all these help us to intubate the patient in prone position. These are the indication of tip, spine surgery, plastic surgery, orthopedic surgery. These are the contraindication is that absolute indication, you know, occipital bone where the fracture is there, or stab in cervical, thoracic, or lumbar region. Contraindication, full stomach If you malampati, if you are examining, there is difficulty in intubation regularly, malampati 3, 4, or then in that case, you are not supposed to, there is a patient unable, his neck, we cannot flex and neck movements are restricted. So in that case also, we should not attempt intubation in prone position. Next. So before you do intubation in prone position, you have to learn the technique. The selection of for elective surgery plays a very important role. See, for prone intubation, because you are not in a familiar position, unless you must select the cases very properly. Then only go for prone intubation. What are the things to be look for? No cervical pathology, no difficult airway, anticipate difficult airway. BMI should be less than 30. Actually, I'm a little this one. We can obese patient also. We can easily intubate the prone position. Mouth opening as usual, more than 3 centimeter. Thyromental distance more than 6 centimeter. No respiratory or cardiovascular problems. These are the requirement while you selecting the patient. Preparation of procedure. Patient is asked to take a comfortable prone position. IV line taken. Secured pre-medication given. Monitor attached to the patient's back. Bolster is passed under the chest and pelvis to make abdominal movement free. But if you use the William table, you automatically fulfill all the conditions. Face is turned to the operant side and pre-oxygenate done according to the standard protocol. Induce with propofol and deeply. And proper size of LMA inserted. Adequate depth anesthesia achieved. Cuff of LMA is inflated as per the instruction and leakage check. ILMA pass through mouth and secured, connected to the vein circuit to workstation, then ventilation check and confirm with the ETCO2. Then I give after passing the intubating LMA, not before, the succinylcholine you can do 1 to 2 milligram per kg. Then either bronchoflex or fiber optic bronchoscope preloaded with ETT and with a continuous oxygen insufflation through its port is passed through the ventilating port of ILMA while visualizing the vocal cords and carina on the screen. ETT is then pushed inside the level of carina and connected to the brain circuit. Ventilation check and bilateral entry is confirmed. Strategy followed in the technique of tip. Learn insertion and removal of technique of intubating LMA in supine position. You must learn how to insert the intubating LMA in supine position, how to remove it. All this you must learn the technique on mannequin and patient. Then acquire skill of inserting LMA in prone position on mannequin, followed by LMA insertion patient in position for minor surgery. If there is minor surgery, after you acquire the technique of passing LMA in mannequin, then you go for minor surgery, not for major surgery. Mannequin study, pass intubated LMA in prone position, and with the help of bronchoplex, with preloaded ETT, pass through the intubating LMA, and you can see the vocal cords and carina. And you see, these are the pictures they show. First case shown the passing the intubating LMA through mouth. After adequate, patients should under the this anesthesia adequately, because it should not be under a light position. Then you pass the intubating LMA. After confirm again by ETCO2 and by auscultation, when you are sure that you have got ventilation in your hand, you are secure, then you can pass the cable of the fiber optic bronchoplex or bronchoplex preloaded to the ENT, and you can see on the screen. Next. You can see the vocal cord. He's just passing that cable preloaded with the. Next. See, I have just shown this video because in our skill lab, so that one can learn from here. Yeah. See, is a mannequin just passing the intubating LMA. Because of this mannequin, there is a lot of resistance. But when you just inflating the LMA, then check with the umbilical. Can you see? Can you visualize? Just yeah, in this case, there is a continuous oxygen, nasal oxygen also, madam, till you to ETT pass. Now you can see it is visible. Then after you confirm that intubating LMA is working properly, then you can pass the endotracheal tube. Now I am introducing this is the method of removal of intubating LMA. Can you see the chest is moving? Yes, sir. Go ahead. Go ahead. Next. Direct tip has the following advantage. Induction instant time is less cervical movement, less manpower. The birds have shown the videos where there are so many people are required to change from supine to prone and prone to supine. Again, the anesthetist has to be very careful and he must take care of the endotracheal tube. And there is also interruption while changing the position supine to change in interest of monitoring. When you do from supine to prone and prone to supine, as it not required to change chest lead, NIBP cuff. If a patient already in prone position and intubated, there is no necessity of changing the chest lead, NIB cuff, SpO2, etc. to prone. Suppose, unfortunately, if we are unable to intubate the patient, and if the SpO2 is going below 95%, then you must take care. You must keep a trolley by the side of your table, and immediately you can turn and as convention. But you must take quickly. Your decision should be quick, and you can ventilate the. You can intubate the patient in supine position and give up your. Yeah. Tip appears to be more safer, easier as compared to the routine method, but requires extensive training, good teamwork, surgeons' cooperation. So I found very difficulty in performing this intubation prone person because there are a lot of hurdle is there. Surgeons are not ready easily. Even our anesthetic colleagues also scared to help. But nowadays, for last 4 or 5 years, I am convinced my surgeons as well as my colleagues. Now we are doing some of the cases, but it requires more people to involve in my this one mission, and they should get interested. I know this is an unpalatable this is a technique. People are not ready to accept. But when you see the Butser's videos, they are very beautifully explained how to insert in prone position. And I hope in future will definitely improve and come this tracheal intubation in prone position routinely. I show there are 3 videos how to insert the LMA in prone position for this abscess or neck position. I think no, it is very difficult, but Bird's videos are very clear and nice. Very obese patient, and yeah. Oh, it does not. No. The second case, how done? See, I'm showing right from beginning. The patient in prone position. All the monitors are attached, and I give pre-medication given. Patient pre-operation is being done, and given propofol, and take patient adequately under anesthesia. And next, this video is not, I think.
Sir, your video is not attached over there. It is just copied. It is not attached, so it is not playing.
Anyway, this is a usual story. Whenever you show some slides, it doesn't work properly. Anyway. See, inserting intubating through the intubating LMA we are inserting. So being inflated and attach circuit. Some other juniors are repeating again this video. After you confirm, next. Then inserting ETT through LMA. Here we give muscle relaxation. Here we necessary to either use choline or cisatrak, whatever your choice. After the relax properly, then afterwards we remove the LMA. When you confirm that the endotracheal tube inside the trachea by ETCO2 and by sculpting, then I remove the. But this technique of inserting intubating LMA as well as the removing the intubation must only frequently. Then only you can try in prone position, not indirect. You must have sufficient this one.
This was fantastic.
Huh?
Really fantastic.
Madam, I can see that people are not happy with this technique, but I'm sure. But if our younger generation learn this technique, right, it will save time.
All the stress.
Huh?
All the stress of
only. Pardon, madam? Pardon? Yeah.
Yeah, all the stress which happens in prone position, like accidental extubation and all. So if you master this technique,
you can, after some time, we must expertise in this one and routine. I hope that people can even try routine surgery also.
Yes, yes.
I have done extubation in prone position. Again, I avoided to turn the patient from prone to supine and give reversal and then extubate patient after. If you can do extubate in prone position also, it's very easy, and this because the tongue is forward fall, secretion drain out, there's no question of secretion. And after giving a relaxation, if the patient comes full out of the relaxation, you can use the train of 4 and confirm that patient has come out of the muscle relaxation, then can very easily can remove in all this. I know, madam, people are not very happy to for this, but
Today they'll be convinced.
Huh?
Today they'll be happy to whatever
What our
you have
ancestor
shared.
should be confident about this first. Then only he convince the surgeon. If you are not confident, the surgeon will not allow you to do all this procedure. So more people should get involved in this procedure, and after it should become. When you started epidural anesthesia, surgeon were very reluctant. No, don't give epidural anesthesia. But we are not an expert in that position. There was some patchy level was coming, and they were not. Now the surgeons is different. They say, no, sir, give epidural anesthesia along with GS and all those things. Extubation done in prone position only after giving a reversal. You should confirm. But these are videos are very long back. You can curve with the help of the train of 4 and all that. Mr. Relaxant have been. Now, as usual, you must because the patient fully awake. Then the third type of this third stage, the same method is followed. Put the intubating LMA, pass the endotracheal tube preloaded on this fiber optic, and you can see the carina, and you can just next.
Very nice.
You can see the cable of the fiber optic, and as the endotracheal tube. Next. Now, next. You can see the the carina, and you can just push the endotracheal tube inside. You can see the through this.
Yes.
One you do blindly. In second case, I show blindly. You can pass the endotracheal tube through the LMA and ventilate. And otherwise, you can, with the help of bronchoplex or the fiber optic, preloaded, and you can pass through, and you can very easy. See, all this effort changing supine to prone to supine, and everything is, avoided. And I wish people should start learning this technique, and they will come when they will also go for the giving anesthesia in prone position directly instead of going all those things. Thank you very much.
So thank you, sir, for such a detailed explanation and convincing us to intubate in the prone position through and supraglottic. The effort of consistency is really appreciated. And thank you for all the important and needed information. And
there are the references. There are one series where they have done 247 cases in daily. Daily they have done an prone intubation, then which 244 cases are very successful.
Yeah, these references will be really important.
Yes.
Yes. Thank you so much, sir.
People are not happy at the beginning stage. When you learn this technique, you'll be much more happy to follow my technique. Thank you very much.
Thank you, sir. You are such a blessing.
Thank you, sir.
But sir also can answer the
Dr. Namazi, you presented very
experience.
You presented
lovely presentation.
I have done couple of cases, but they were not recorded very nicely, so I did not show. And then you were able to show me. आपके सामने mic कैसे दिखाएगा sir?
आपने तो अच्छे बताए.
I have a lot of respect for this man. He is very humble and he is such a nice person. Thank you, sir. Thanks a lot for sharing.
There may be a lot of questions. I know it because there are always, whenever you do any technique, you will face. You must be ready to face the complication. I will say the competent physician, one who can think of the complication and is able to treat also.
So this is a recommended method of doing it. So there is no harm in doing it if it is doing in a justified way. So you can continue. It is already there in the
Books
literature.
and
People are doing it. There are enough studies about it. And at the
When
video,
I presented the cases at many places, people's very not happy and
But if you have a fiber optic to guide you,
yeah, yes,
it will be definitely
under vision is
yes,
better.
under vision.
no, sir has
First,
done
I
really
try
well.
only in prone position, simple insertion for
Yeah.
small carbuncle or lipoma and this one. Still, the orthopedic neurosurgeons are not ready to help me.
Sir, we would rather call you to Mumbai to do
That's why I wanted, sir. But
We'll
sir,
wait
if
for
I will use
LMA fast track, sir.
for this machine of a tip tracker, I'm ready to come anywhere in the world. There was in Switzerland, one fellow was doing intubation routinely in prone position.
Oh.
And I wrote to him. Then he replied me. Unfortunately, the anesthesiologist, the only person who is doing routine, he expired it. Otherwise, I wanted to go and as observer.
I'm done. Thank you very much. Thanks a lot.
Thank you, sir. I'm very glad to see you, sir.
Dr. Mayur.
All the members of
Thank
your
you, sir.
general club, I'm very thankful to everybody.
Thank you.
So it was a fantastic session.
Yeah.
The video session was fantastic.
Yes,
definitely.
yes.
So,
Yes.
We also
But I
learned so
will
much.
keep
I
a
request
word of
everybody.
caution, sir. I'll give a word of caution because
Yeah,
people
yes,
should
ma'am,
not
yes.
directly go.
No,
You are
no,
an
no, no.
expert, and Dr. YB sir is also an expert. So people.
I advise not to go directly.
Yeah.
You must
Learn.
learn the
Learn
technique.
first.
Yeah. You can use help of your
For
colleague
small
or
surgery, you can use.
go
Then
to
go for.
Dr. Namazi.
Then go for yes. Never indirect.
We can do it in a team,
Yes.
sir,
Life is
in
more
clinical.
important.
Yeah.
Apart from
Start in a team.
cardiac arrest can occur. Nobody will you spare you.
See, this is an lateral thinking in the sense if you get stuck in a case, people do under spinal and prone, and you are stuck, you keep this option ready of passing
Yes,
an
of
LMA.
course. That's
Yes.
what sir told. PCNL or
Yeah, and sir said
then
all
you-
the safety measures like keep a trolley, use a fiber optic,
yes.
use all the monitors.
Recently,
So
I was intubating one patient. There are no any air entry and all those things. Waited for 2-3 minutes. I said immediately turn the patient and make a supine. You must. That's why I told the good competent physician one who can ready to treat the complication, and you must know what are the likely to occur. The cup of this get folded and you can get obstruction. Everything is possible. But still, I always say this is very better. If you go and think as compared to the conventional method, this method is, I think, much more, I think, safer because you cervical movement less, and everything is possible. Time is reduced.
Yeah.
Induction of.
Just like to say a couple of sentences. Dr.
Yes, ma'am.
Namazi and Dr. Bhatt, a picture is worth 1,000 words. So visual techniques or visual videos carry a lot more impact.
Yes.
And as you have said, this platform insists that having doing this in a controlled environment is very important. With all the safety features around us, a group of members around us who are ready to, help us out in case things don't go out. But once mastered, then this can save us from some unexpected situations that can arise.
That is the first
So, so fantastic, Dr. Namazi and Dr. Yogin Bhatt, you are great as always. We could see all the range of LMAs over one journal club. What more do we want? Which one to choose should not be a question that gets asked.
I also learned many things.
It has answered all the questions.
Absolutely.
Very nice presentation.
Thank you for making me a part of this club.
You must give training to your assistant first. Not only yourself get trained, but your team should be very much ready to handle this odd situation.
It's a teamwork,
Yeah, it's a teamwork.
So thank you, everyone.
Thank you. I'm very much glad to
Let's
see all you
see over
people.
to Kala.
And you are invited to come to DY Patil. I am
Yes, surely,
twice,
sir.
madam. I am twice retired. One from the as a class 1 officer in government medical college. Then I was in DY Patil. Still I am there. There
Yeah.
also I retired at the age of 70. This is for 7-8 years before. And
Oh.
still I am working as a emeritus professor. Already you know all the Marathi. I have just sent. Every year I conduct the World Anesthesia Day, writing some
Oh.
skits and so make for public awareness. And I sent to Birdsar, and Birdsar appreciated my work. I think everybody is knowing Marathi and all those things. Okay, and thank you very much. Go
Thank
through
you.
that.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you.
On behalf of ISC, I'd like to conclude the session and give vote of thanks to Dr. Abade for conducting such a wonderful session, and Dr. Sonali and Dr. Soma for being our guide and mentors, Dr. Shweta, Sachin, and Mayuresh for an excellent presentation, and our expert video sessions by Dr. YB sir and Dr. Namazi. It was wonderful interacting, and hope there is a lot of take-home messages from here. And just a word of caution, be careful, keep the safety measures, and use the ETCO2 and your circuits very well.
Yes.
Thank you so much. YB sir, should we continue?
Yes. You
Oh,
all can.
Sonali? Fine.
Birdsar, can I say Birdsar? What's his opinion? Birdsar's remark.
I think sir is muted.
Not there. Okay.
Yeah.
Yeah.
Okay, we take leave, sir. Thank you
Yes.
so much, Dr. Namazi.
Thank you, sir.
Thank you.
Thank
Yes.
you. Yeah.
We conclude this.
Thank you, everyone.
Okay. Thank you.
Okay. Thank you. Okay. Good night.
Good night.
Thank you.
Thank you all. I will conclude the session.
Yes.
Yeah. Thank you, ma'am.
Thank you all.